I just built few other newer like topics, and I know whenever residents work with me or ask me, there's a lot of questions about the diabetes drugs. And so I just kind of built that into one of the questions, and then I went a little bit into the adrenal issue. So I didn't go into bone because Nelson didn't say bone, but when I went into the board review, I did see a few bone questions. You're welcome if you want me to log on into his thing. We could go over some bone questions if you all have any questions. There's about 30 or 31 questions in the mix app that he gave, and they were all kind of mixed with, neuroendocrine and diabetes and bone. So if anyone has any questions related to one particular, if you've already reviewed, I'm happy to address that also. You can stop me anytime. So with that, we'll keep going. Okay, so I'll start with the first case because I don't know who was, if anybody was rotating with us last month in endocrine service. I'm usually on in March. We had a very interesting patient about, I think, mid-March. He is, I know this is getting recorded, so it'll be online, but is a kid who came from in Midwest area in one of the colleges and was attending a seminar here with his family just as a vacation also, and became quite sick while he was attending the seminar, attended only half of the seminar and had to be hospitalized to our hospital, not at university but our other tertiary hospital. So, and we were consulted to see him because he came in DKA. And I recall that one of the, I think whoever was rotating with us, perhaps one of the nurses who was in the room said, usually when you talk about type 1 diabetes patients, usually they are lean and, usually the BMI is like 20, 25. And this is a kid whose BMI is like 40 something. And, there's no other type 1 in the family, there's type 2 family history. And he was in Florida DKA. So, of course, we took care of him and he went back to where he came from, and the mom called us and thanked us profoundly for taking care of him. So this patient is sort of similar, built around the same history without going into too much specifics. He's an 18-year-old boy evaluated for excess urination and thirst, been drinking 5 liters of fluids daily for the past 2 months, and mom is type 2. On physical exam, the vital signs were normal, and his BMI is 35 kilograms per meter square, and the rest of the exam is unremarkable. In this patient, this was an outpatient visit with the pediatrician or med-peds, whoever he was seeing, and of course there was no, he didn't look ketotic, he didn't look ill. The physician went ahead, did a A1C, it was 8.9%, so obviously he is diabetic, and blood sugar is 324, and his electrolytes, luckily for him, were normal, and his ketones were negative, so the physician knew to check off his ketones right away. So the options are, next step, this is an 18-year-old, and comes into the office, his on the heavier side, obese, A1C is 8.7. Of course, not in the hospital, he's not ketotic. So what is the first next step to do? Because there are several diagnoses that could come in mind, and if it's 18, he's almost like an adult. So, so one option is the C-peptide, fasting C-peptide. Those of you, everyone is familiar with what a C-peptide measures. It measures your islet cell or beta cell function for anybody with, looking at the beta cell reserve. C-peptide postprandial, which is meal-stimulated C-peptide, which we do sometimes. For patients, we are planning on islet cell transplant to see what the islet cell reserve is or beta cell reserve is. You give them a mixed meal, and just like you do a glucose tolerance test, this is called a mixed meal test. You do at an hour 0, 30, 60, 120 minutes, you look at the insulin, C-peptide, and blood glucose levels. And, of course, the third option is fasting insulin. And the fourth option is islet cell and glutamic acid decarboxylase. Sorry, I split the decarboxylase there. We call it GAD65 antibody titers. Any takers here? Probably everybody knows the answers already. I'll have the chief resident volunteer someone since I don't want to call names because this is being recorded. Raj, you want to volunteer? So what would be your choice? See.
Young, and he seems like type 2 diabetes.
Yes, he seems like type 2 diabetes. So what would you measure?
Antibody titers.
And yeah, so antibodies is the correct answer. Why are you measuring the antibodies?
Check for type 1 or type 2 diabetes.
Okay, so your answer is correct. You do measure antibodies. So the presentation does fool all of us, right? If this was a person who's 10 years older presenting like this, you probably won't even think about the fourth choice here, which Raj just said, which is the islet cell and the glutamic acid decarboxylase antibodies, because most of your adults presenting like this in the office would be a type 2 diabetic. However, when it's a child, is 18, still a young adolescent to young adult, so still even with a family history of type 2, if you look at the studies, younger children when they present, the first thing to rule out is type 1 diabetes, which is checking the GAD and the islet cell antibody. And many times, not all of them have to present with DKA, because by the time they present to DKA, there's so much glucotoxicity that they start spilling ketones and present with that. But many times, oftentimes do see them in the office when they still have some beta cell reserves, so they don't go into DKA. And there is a significant percent as we are becoming, or maybe this year I think we are more stable, but as a nation we are kind of getting more obese. Many of your type 1s can present with obesity, and sometimes we call it double diabetes. They are obese, but they are type 1, and they have insulin resistance, so they end up needing a lot more insulin than your regular type 1 does, but it's weight-based, and so you can't be fooled just looking at the BMI. You have to look at the child's age and make sure you don't want to miss a type 1 diabetes. And the incidence, if you look at the data about the type 1 diabetes incidence globally, slowly it's rising over time. And as you all are familiar with, many of your type 1s can present adults, and that's called as LADA, late onset diabetes of the adult, LADA, and that is also a significant percentage of patients. So anyone has any questions related to that as to what to do? So assuming he has, and so this is similar to the patient I saw last month, and I saw exactly the same patient a year ago also among the three hospitals, the other hospital, who also came in with DKA. In fact, parents, I think, were in the healthcare field. So they were very shocked because there was no family history of diabetes. Exactly the same thing. This was 18, 19-year-old. So every March I'm seeing at least one young adult with a new onset type 1 diabetes. So that's something to keep in mind. So Nelson wanted me to discuss the different kinds of diabetes and go over a little bit about the complications, so I'll spend a few minutes on that. So your most common diabetes that we see, 90 to 95%, is the type 2 diabetes. And as I mentioned, double diabetes, which is many patients with type 1 who look like type 2, and sometimes we end up trying metformin in these patients to decrease the amount of insulin that they end up requiring. And the type 1 diabetes is antibody-mediated. It's typically juvenile, young children, but we could see 20 to 30% in adults also. And the type 3C, which many of you all who have been in service with us may have seen a lot of them now that we have the islet program here, is post-pancreatitis diabetes, and also patients who have pancreatic diseases, which can cause endocrine and exocrine impact on diabetes. Endocrine is the impact on the pancreas, which is the diabetes, and also the exocrine pancreatic insufficiency, which is patients with cystic fibrosis that we have a CF program here. So those patients, that CF-related diabetes is known as the 3C diabetes also. And of course, gestational diabetes, which many of you all may be seeing in the clinics, and maturity onset diabetes of young adult, which is something we don't see as often, but it's one of the most interesting genes. It's a HNF gene, and you can see generation after generation of young adults with diabetes. They are very well controlled. Interestingly, they don't develop any complications. It's kind of rare, but it's mutation, and the scientist who discovered the mutation is in the University of Chicago. I happened to meet him a few years ago at the ADA. And also pre-diabetes, which at least the incidence is rising in about 20 to 21% of adults can have pre-diabetes undiagnosed. And in fact, that is where we need to concentrate a lot more as internists, so as to prevent diabetes occurrence and complications related to diabetes. Secondary diabetes, which most of you all, since we have a very large transplant program, liver and kidney transplant, solid organ transplant, so you end up seeing a lot of these patients in the clinics and in the hospital. And this is related to the immunosuppression agents that we use, the calcineurin inhibitors, the Prograf, cyclosporin, and all of that. They also can have transplant osteoporosis and several other endocrine issues, lipid problems and everything. So by itself, it's a talk on its own, transplant endocrinology. Of course, patients with HIV, it's a very classical diabetes. It's related to the lipodystrophy, which many of you all take care of those patients, and steroid-related hyperglycemia, which can, over time, these patients can develop diabetes. And diabetes related to syndromes, which many of those patients we see in the clinic. In fact, I have one of them. There's only 600 of those patients in the whole world, and we have one of those patients. It's the Alström mutation. It's Alström syndrome. So those patients have very interesting diabetes with severe insulin resistance and early fibrosis of all organs. So, and diagnosis for diabetes, which you'll definitely have at least one question on this. And so until 5 years ago, if somebody asked you, the only answer you would give is the gold standard, which is the 75-gram glucose tolerance test. But about 4 or 5 years ago, we have started using the A1C of over 6.5% as a diagnosis. However, when you come up with an answer for diagnosis, you want to incorporate A1C over 6.5 and also perhaps a random blood sugar of 200 or a fasting blood sugar over 126. Or the other way of diagnosing, which we don't need to do it much anymore because most of our patients, we are aggressively doing pre-diabetes evaluation and yearly repeating the A1C, so you end up diagnosing them without the gold standard testing, which is kind of elaborate and very labor intensive. The 2-hour plasma glucose and the amount of the glucose used is the 75 grams, and the normal range fasting should be less than 100, and pre-diabetes, which is impaired fasting glucose, 100 to 125, and of course if they are over 126 they are diabetic, and the 2-hour postprandial 140 to 200. And if they are between 140 and 200, they are pre-diabetic, and if they are over 200, definitely diabetes. And the same thing goes for random patients who present with hyperglycemic symptoms of polyuria, polydipsia, along with the blood sugar over 200 also is diabetes. With the A1C, I know today when in the clinic we had a patient that Jara and I were seeing, and his A1C was 6.2, but his clinic blood sugar was 220 or something. And then we realized that he had been just transfused a few days before he had the A1C done. So that's a caveat. Since you're in a university setting, you end up seeing a lot of complex high acuity patients. So it's important to find out, are they having any hemolytic anemia? Did they have any recent transfusion or anything, any hemoglobinopathies which can affect your A1C? And for a given A1C, usually there's also some mild racial differences. Perhaps with a higher A1C in African Americans, their sugars can be lower than their counterpart Caucasians, and those studies are also out there. So it's important to remember this because patients get very upset when you tell them you have diabetes and when it's only 6.5. So you have to really make sure that before you document it, there's enough data there before you permanently call them type 2 diabetes. Complications, some of the major complications I think all of you here are familiar with, such as the cardiovascular complications. But the ones that I wanted to focus is things that we don't think a whole lot about because, in a busy clinic day, we look at their lipids, we talk about aspirin, statin, and ACE inhibitor, urine protein, but we kind of don't think a lot about autonomic. And since we also have a huge motility program, and I'm quite involved in seeing a lot of these diabetic gastroparesis patients, I felt like it's something when you're in a regular clinic to pay attention a little bit to some of the autonomic neuropathy complications in type 1 and type 2 diabetics. One of the things that many patients with diabetes present with is abnormal sweating patterns, which is they have absent sweating sometimes, especially they do say, I feel I sweat inappropriately, like when I'm eating, I'm pouring into sweat all the time or right after eating, and when I'm in a social situation, I tend to sweat and I have to go and change clothes sometimes, and sometimes they have what we call as distal anhydrosis. So that is something you notice sometimes as a part of autonomic neuropathy. Abnormal pupillary responses, the Argyll-Robertson pupil, which is decreased pupillary dilatation in the dark. That is also something that you could notice sometimes. And the one thing that we see often in the clinic is impaired response to hypoglycemia, meaning these patients stop feeling low sugar reaction, which you call as autonomic failure, which actually is our next question, actually. Cardiovascular, big problem. Postural hypotension is a very big problem, especially patients, you see them in the clinic, their blood pressure is running high, you titrate their medication, they go home, they come back, they're always dizzy. Dizziness is a big problem. So postural hypotension, postprandial hypotension, fixed tachycardia, which is a very classic diagnosis for cardiac autonomic neuropathy in long-standing, poorly controlled type 1 and sometimes type 2 diabetes is fixed tachycardia. There's no beat-to-beat variation in the heart rate. Our physiologist here may be able to confirm that. So, foot complications, which all of you are familiar with, neuropathy, sudden cardiac death, which is actually one of the dreaded complications in type 2 and type 1 diabetes, is the higher occurrence or prevalence of sudden cardiac death. Gastrointestinal, most of you all are here are familiar with having a very busy and active GI hepatology service. Most of you all see this, the GI complications of diabetes, and you probably have seen the whole spectrum of it. The esophageal motility disorders, gastroparesis, constipation, diabetic diarrhea, fecal incontinence, and the small intestinal bacterial overgrowth, what we call as SIBO. Those are all complications of long-standing diabetes. In fact, the fecal incontinence can be very disturbing in these patients. Genitourinary, again, I have one patient who has everything. He's only in his 20s. He has bladder dysfunction, so he has to, neurogenic bladder, so he has to straight cath frequently, so he won't end up with urosepsis. He has gastroparesis, so he has a stimulator. He has severe hypoglycemia unawareness, so we had to end up getting a pancreas transplant for him. And he also has arrhythmias, atrial fibrillation, so it can be pretty problematic. And this gentleman is just in his 20s or 30s now. So bladder dysfunction, ED, very common, sexual dysfunction. Retrograde ejaculation is also another issue that you see in these patients. So I just wanted to bring to your attention that there is combination basal GLP-1 receptor analogs available, degludec and liraglutide together. It's called Zultofi. It's been in Europe now for almost a year, but we just got it FDA approved. And also glargine and lexisenatide, that is called Soliqua. If you can remember these names, then you're good. They come up with more and more difficult names. So this is a 38-year-old man who's being evaluated after having 3 episodes of severe hypoglycemia in the past month. He has a 19-year-old history of type 1 diabetes. We just talked about some of the complications. He has a history of unawareness of hypoglycemia. And he has mild background diabetic retinopathy, peripheral neuropathy, and orthostatic hypotension, all the complications of autonomic neuropathy. And his medications, a basal analog insulin, 28 units at bedtime, and Lispro, which is Humalog, 6 to 12 units with meals. He does not do carbohydrate counting. He just does, he tests his pre-meal. Hopefully he does test it every time, but and he uses the insulin based on how he's eating. His vital signs are fine. His BMI is actually 32. He actually has gained some weight because if you're aware, hypoglycemia does cause some weight gain. And the lab studies show A1C is 6.6%, so that kind of shows you that he probably has significant hypoglycemia for him to have less than a 7% A1C. So and he has no evidence of microalbuminuria. So all he has is autonomic diabetic neuropathy. Some of the following options, one of the options, so increases carbohydrate intake at meals, decrease activity, decreases insulin doses, or choice number 4 is insulin dedimer, which is Levemir, which you're all familiar with, for insulin glargine, which is Lantus. So, who wants to answer? It would decrease his insulin dose. Okay, that was the right answer. Why would you not give him more carbohydrates with meals? Okay, his BMI is 32, right? He's a type 1, his BMI is 32. And why would you not switch the dedimer to glargine?
Yeah, glargine is more the long acting, and so it'd be more peak so fast.
So
glargine more so one a day. Then you can do one a day. You might end up having to do twice a day.
Yeah. So all your answers are correct. The weight gain is a big issue. Activity, you never want to tell someone don't be active, right? So we always, if they are active, we really want them to. The number 4, one of the answers is what you said, that it really doesn't make a big difference. And one of the other reasons is nobody asked me when is the hypoglycemia, right? That is very important to know. You want to know, is it postprandial? Is it overnight, nocturnal, or is it any other time of the day? Like I have a patient who was doing really well, and then she's a journalist, and few weeks ago she started having more and more hypoglycemia, and we are trying to figure out her diet is the same, nothing much is very different, and then we realized, then I asked her, she says, I work out the same. Then we find out later that she's joined the OTF. I don't know how many people here are familiar with the Orange Theory Fitness, which is like a extremely intense program, and she does it 3 times a week, and of course, those days, overnight, she is dropping like anything. So one other thing with type 1 diabetics and type 2 diabetics on insulin is that even after the intense activity is over, depending upon the combination of the resistance and aerobic exercise, they can continue to drop and be more insulin sensitive late in the night, into middle of the night and early mornings, up to 12 hours after the exercise. So it's very important to remember to tailor their needs based on their activity, and type 1s are extremely sensitive to that. So Jara was right about decreasing the insulin doses. That would be my choice too. So that brings us to the...
Well, what did endocrinologists think about ACP changing the A1C to
Oh yeah, I knew you were going to ask that. I was trying to avoid that question. just like a year and a half ago when I was at ASBMR, the American Society of Bone and Mineral Research, that's when ACP also came with this very simple algorithm for osteoporosis. And there was a lot of argument. In fact, there was a debate about it, and the person who won got the Golden Femur Award. So this has caused a lot of kind of excitement in the wrong way. ADA kind of released a statement just, I think, March 8th is when ACP came up with that. And within 48 hours or so, ADA, American Diabetes Association, said, we are deeply disturbed by this, statement. It seems very blanket. Part of it, I really agree, and which we have talked about it all the time. It has to be tailored to the patient. So if you have a patient whose life expectation is 5 years from now, or if there's somebody who's at a very high risk of hypoglycemia, such as this gentleman, who may be driving and crash into a tree, hurt himself, hurt someone else, and several other, those patients, you want to relax their targets to 8%. But majority of the, I didn't put the slide that I always use in every one of my diabetic talk, and that is the DCCT slide, which you may be familiar with in New England Journal of Medicine, showing the tight control early on, A1C versus, the ones that were conservatively managed, and how your cardiovascular complications were even 10 years later. That's why it's called the legacy effect or the metabolic memory. So I think many of us don't agree with it. We agree with part of it that, yes, not everybody needs to be aggressive. I have some 75-year-old patients in the hospital. We were actually having a big argument with the patient who was admitted with ventricular fibrillation, and she's recovered, and now she's rehabbing and insists on having blood sugars below 100. And here I'm telling her, no, you've had 30 years of diabetes, you had VFib, there's no way. So I think part of it is right, that it is targeted based on the patient. It's patient-centered treatment, but part of it telling that everybody can be 7 to 8% is kind of tricky. So, because there are patients like pre-gestation, or young women who are planning pregnancy. The obstetricians, ACOG will tell you they don't want patients getting pregnant if they're over A1C of 6.5, which to me is kind of a tall order, but still they're very insistent for the outcomes, mainly for the outcomes related, fetal outcomes and the maternal outcomes. So I think that's been a big argument, and I'm sure this summer in ADA they'll have a big kind of a debate about it. So definitely that's a good question. So autonomic failure, most important to remember is this is where the glucose thresholds are on the bottom here, and these are your rescue hormones that come into effect as the blood sugar drops. When you're at 80, usually when somebody has an intact system axis, not a type 1, a regular, like you and me, all of us who don't have type 1 diabetes or who are not on insulin, usually your insulin, pancreatic beta cell insulin secretion drops. When your blood sugar goes to 70, your glucagon starts going up. That's from the alpha cell. So it's called the islet crosstalk. Within the islet, you have the alpha, delta, and the beta cells. So there's islet crosstalk. When your sugar goes down, your insulin goes down, and glucagon goes up. And that's what is messed up in diabetes in a way. There's a mismatched glucagon release many times. And then as the sugar goes lower and lower, epinephrine, and after that growth hormone, which is what is missing in hypo-PIT patients, and then cortisol levels start going up. And then if none of this goes up, and if the patients do end up going close to 40, then they get confused, which is classic triad, Whipple's triad of hypoglycemia: confusion, neuroglycopenic symptoms, and then response to blood glucose by resolution of the symptoms. So I'm not going to go over this whole kind of very complicated pathway of defenses against hypoglycemia in humans, but the summary of it is what I just showed you earlier. But there are several players into this, and it's a very complex system. And since I think last time when I was doing this talk, somebody did bring up the issue about now that there's the Facebook issue going on, they did bring up about, the tampering with devices, because we use a lot of iCloud. As you can see, this is what we call as a continuous glucose monitoring system, which is many times used in patients who have unawareness, hypoglycemic unawareness. And I think one of your chiefs at that time asked me, what about somebody, tampering into these systems, with everything being in cloud data right now. So that is something all companies have to worry about. So as Jerem mentioned, if you look at Dedimer and Glargine, not a huge difference. Of course, Glargine a little bit longer than Dedimer, but not really big difference. So when you had to pick, I would pick the cutting back the insulin rather than switching to a different insulin. Let's see. Are we stopping here, Chris, or are we going a little bit longer? Yes, keep going. Okay. So I also, since many of you have sometimes asked me about the different insulins, I thought this would be a good time to talk about it. So the older insulins, which still in the market, which we use still quite a bit because they're very cheap. You can walk into Walmart and get for $25 an insulin vial, which, if you have the newer analogs, if you're not insured, it could be a problem. The older insulins, the regular insulin, which is the mealtime insulin, and then the NPH, which is the one, patients call it cloudy, but it's the intermediate acting insulin. U500, which we had a couple of patients in the clinic today, which is 5 times as concentrated as the regular insulin. I call it the mother of all insulins. And it's pretty potent, and we use it in patients who require more than 250 units total daily dose of insulin. And of course, the older insulins also, we have the Premix N and R, NPH and regular. The patients who can't take multi-dose, like 5 shots a day, this is easier. You premix and give them 2 a day. At least they're getting the 2 shots a day. But it's a little difficult to have very good control with premix insulin as opposed to basal bolus insulin. The analog insulins available now as of 2 days ago, updated version of this. Everyone is familiar here with this is the mealtime or the rapid acting or the prandial insulin. Lispro, which is Humalog. Onset is about 5 to 15 minutes. It lasts up to 4 hours. Glulysin, which is Apidra. We don't use it as often here. 5 to 15 minutes. Similar, 1 hour. This insulin is unique because we could use it even if the patient forgot to take it before meals. They can still take it up to 20 minutes right after the meal. Aspart Novolog, most of you are familiar with this. Similar PK/PD here. Little bit longer, 3.5 to 5 hours, and again meal time. And the Fiasp is just recently approved, first in Europe and now here. It's called NovoRapid in Europe. Fiasp, the onset of action is actually less than 15 minutes. This is tailored for patients who forget to take their mealtime insulin all the time. So their action is 1.5 to 2.2 hours, but it can peak and last until 5 to 7 hours half-life. So mealtime, and it can be again administered within 20 minutes after a meal. So that is the advantage of 2 of the 4 of these. And the basal analog insulins, most of you are familiar with the Glargine, the Dedimer, and the Basaglar, which is the generic version of the Glargine, and the Degludec, which is the Tresiba. There's a U100 and a U200 version of it, and it lasts up to 42 hours, the tail end. So, and we did one of the studies for it for the cardiovascular outcomes. So it is the longest acting insulin among the basal analogs available. And the concentrated insulins, we already talked about the U500, but the other 3 concentrated insulins, those are, when you talk about insulin, usually it's U100, which means 1 ml of the insulin has 100 units in it. The concentrated insulins, 1 ml can have 200 or 300 in this case. This is U300 Glargine. You may have some patients on this. It's called Toujeo. And U200 Degludec, which is Tresiba. The PK/PD of these are much better, meaning they're suspended and they slow release, so they're they kind of are more long-acting compared to their U100 analogs. The U200 Lispro Humalog is the only rapid-acting concentrated insulin available, and I have found it very helpful in patients who need large amounts of prandial insulin, like over 60 units, because when you give them this, instead of the 60 unit, you give a 30 unit concentration with 60 unit strength, so it works much better. And I've had at least a couple of pregnant patients I had to use this because they were quite insulin resistant and I couldn't get them to the target amount. So, and the Premix insulin, of course, we have the Novolog Premix and the Humalog Premix. I use the 50-50 more for patients who eat a lot more, so they need more basal and less, more bolus and less basal, and the 75-25 for those patients who are picky eaters, like your pancreatitis patients. So we'll go to case 3. Should we just keep continuing, or do they need a break? Ask the chief residents. Just keep going? Okay. I didn't see anyone sleeping yet. I don't hear snoring, so that's good. But please stop me if you have other questions unrelated to what we're doing here. So I'm done with the diabetes part, so that's a good thing. So 78-year-old male, this is case 3, evaluated in the ED for a 1-day history of nausea, vomiting. He was discharged 3 weeks ago after exacerbation of COPD, completed glucocorticoid taper about a week ago. Several COPD exacerbations requiring similar treatment. So that's your kind of important statement right there. Medical history is otherwise unremarkable, and I put her here. It's actually his only medications or inhalers on a maintenance basis. Physical exam, blood pressure 97/75, little tachycardic, and respirations are fine. Decreased breath sounds and wheezes, given that patient has a history of COPD. Tender abdomen with no rebound, and extremities warm and dry. Lab data, sodium 126, potassium 3.9. Urine analysis is positive for some WBCs and bacteria. So the patient is given normal saline and started on broad-spectrum antibiotics. And the blood pressure in an hour is 78/50, still tachycardic, blood sugar is 58. Any takers? What do you think the patient has at this point? I didn't hear that. Okay, so now that you've answered, following next appropriate step in treatment, dextrose, hydrocortisone IV bolus, hypertonic saline, norepinephrine, that is pressors. Answer? B. Okay. So why do you think they have...
Because from the history you can tell he's been on steroids.
Steroids, yeah. So what do you call this condition? Tertiary, yes. Okay, you already did your endocrine stuff. So, everybody familiar with that? Tertiary adrenal insufficiency. So, primary is we'll have another patient with primary, but primary is Addison's, or patients who had adrenalectomy or other reasons with primary adrenal failure. Secondary patients are those with pituitary issues. Tertiary are those patients who have been on steroids, steroid dependent for long periods of time. Sometimes doesn't have to be long periods, as much as 6 weeks at a time. They're on it. They can be adrenal or ACTH deficient for several weeks after that. And so that's why it's very important when you're doing an OR evaluation, like a pre-surgical, to always ask patients about recent steroid use, because you'd be surprised how many of them can crash during surgery. Raj is right. So patient has tertiary adrenal insufficiency, and hydrocortisone intravenous bolus is the right answer, and because patient has adrenal crisis at that point. So, sure.
So, how do you approach a patient, diabetic patient who we started on steroids? Like, from my understanding, I usually 30% dose of total daily dose of insulin. Is that
Okay.
usual approach or is it different?
That sounds right. I have that slide in the end of the talk, so I was not going to talk about it, but since you asked, I'll talk about it. But that is one of the options. Yeah. So, but we'll certainly come to it towards the end. So, the question was, how do you approach uncontrolled diabetics who end up needing steroids? Then how do you manage their blood sugar? So, we'll get to it later. So, case 3 is a 30-year-old male evaluated with 2 days history of fever, cough, nasal congestion, myalgias, and fatigue. So this patient already is diagnosed with primary adrenal insufficiency less than a year ago, and is already on hydrocortisone and fludrocortisone, and he has been taking the medications as scheduled and fluids as needed. And this patient comes in with a URI, so low-grade temp, low blood pressure, but no orthostatic. So the provider knew already to evaluate, the physician knew to check for orthostatics. Heart rate is 78. Respirations are normal. Posterior pharynx erythema and cervical lymphadenopathy. So what is your next step in this patient? So I just put this picture in of a patient with adrenal Addison's. Anybody notice any physical, things here that you look for, markers in Addison's autoimmune disease? Any takers? Okay, so I'll tell just in the interest of time. So this patient has vitiligo over here, which is autoimmune skin disease. Many patients with one autoimmune disease can have other autoimmune diseases. You all may be familiar with the polyglandular syndrome, polyglandular autoimmune syndrome, type 1 and type 2. Type 1 is pediatric. Many of those patients have mucocutaneous candidiasis, adrenal insufficiency, thyroid disease, and type 1 diabetes. Type 2 is adult, and they have primary ovarian or testicular failure, type 1 diabetes, adrenal insufficiency, and they can all present with vitiligo. As you can see in this patient, vitiligo here, and this was after treatment actually. You can see between the vitiligo and the skin tone here how hyperpigmented they are. And a few months after treatment, the skin tone is actually much improved. And also this is the buccal pigmentation here that you notice here in this patient, which is also classic. Many times if you don't open their mouths or look at the creases and scar areas, if they're untreated, they present with hyperpigmentation. So that is one of the classic markers of Addison. So what is the treatment in this patient? Choices. Oh, I went to the next one by mistake. So actually, I didn't put the choices here, but the choice was antibiotics, number 1 choice. Number 2 was continue whatever they're doing because it's viral. Number 3 choice was hospitalize them and start IV fluids and high-dose, stress-dose steroids. Number 4 choice was increase their hydrocortisone, but not their fludrocortisone. So what would you guys choose? 4? Okay, thank you. So 4 is what I would go with. So 4 is where it's what you call as the sick day rule. So patient is well educated first when you diagnose them, that when they come in with any illness, that they double or triple their doses. It's called a sick day rule. 3 times for 3 days kind of rule. So, and the other thing which is not mentioned here is to make sure that they also are on, they have a bracelet that they wear which says they have Addison's. And the third thing that I always do is make sure the patient has a kit. It's called an emergency steroid, a Solicartov kit that we give the patient. Anybody with Addison's that they can carry with them, so that if they're not near the nearest emergency room and they start having symptoms of Addison's crisis, they are educated to inject themselves with the kit while they're trying to get help. Because once they start throwing up, the 3-day rule 3 times doesn't help anymore because you're throwing up your oral medications. But when they're feeling well and it's just a mild URI, they're well hydrated, they're able to swallow their medication, then it's okay to give double the dose for the stresses. So that's what I would do. So that brings us to adrenal emergencies, which are several, but some of them are florid Cushing syndrome, which, yes, sorry, I missed that. Go ahead.
So, just like with regard to increasing steroid doses and adrenal insufficiency, how about for like which patients, like for instance, who are on chronic steroid therapy, for instance, patients like who have autoimmune disease, should people on chronic prednisone?
Yes. Anybody?
And what doses of
So the similar, what we did with this is double or triple their baseline dose. So all our immune transplant patients who come into the hospital and they're sick, we don't leave them on their 5 milligram prednisone, which they take. If they came in for illness, usually we double up to 10, or many times, depending on their blood pressure and other things, we give them IV steroids. So all the patients who have what you call as a tertiary adrenal insufficiency definitely need to have stress dose steroids available. And I tell all of them to wear bracelet telling, like many of your autoimmune patients or patients pan-hypopit who are permanently on steroids, which is ACTH deficiency, or patients who are on steroids for other reasons. Interestingly, I've had one patient who had been on every few months epidural. Also, they're close to the similar risk, although one would argue that there's no data on that, but many of them do have relative adrenal insufficiency, those that get epidural, because you're putting the injection in a very avascular space. So what happens is that it stays there long, so they do have some relative adrenal insufficiency. So that is one history we ask is joint injections, epidurals, Kenolog, or other steroid, COPD, asthma, and GI issues, autoimmune diseases. So there's a big list of them. They're all tertiary adrenal insufficient, and certainly they're all at risk. Most studies say that the primary Addisons are the highest risk, but there were 1 or 2 studies that I had to review because I had to do expert opinion for one of these cases that you were talking about, where the patient had been on steroids for a long term and went into crisis and had to be, I think, transported to a huge tertiary facility that their argument was the physician taking care of them did not train them to do this thing. So it's very important to educate all your patients that they have to do it. So that's a very good question that you brought up. So, any other questions related to that? So adrenal insufficiency, pheo and paraganglioma. I think you guys have had 1 or 2 pheos that you have sort of suspected and referred to us. Adrenal suppression, which was related to the most recent 2 cases. Endocrine hypertension. CAH, congenital adrenal hyperplasia. Emergencies with these patients are similar to Addison's. They can also go into crisis, so it's very important to educate these patients. And the last one doesn't, it's not in our area. So adrenal crisis, lab and clinical features, dehydration, hypotension, shock out of proportion to the severity of current illness, just like the patient we had earlier who had been on steroids for COPD. Nausea, vomiting with history of weight loss and anorexia, abdominal pain, many of them present just with acute abdomen. Unexplained hypoglycemia, we just saw that in that case. Unexplained fever, that is one way that Addison's crisis, they can present with unexplained fever. Fever is very common in all endocrine emergencies. Addison's, pheochromocytoma, thyroid storm, so we get all excited when we see a patient with fever. So hyponatremia, hyperkalemia, azotemia, hypercalcemia, and eosinophilia. That is more common in patients with Addison's. But as we saw just in the most recent patient, if you have central or tertiary adrenal insufficiency, you don't have to have hyperkalemia. They can present with hypokalemia also. Hyperkalemia is more often seen with Addison's because they have both mineralocorticoid and glucocorticoid deficiency. So hypercalcemia, again, we see sometimes with Addison's. I've had at least one patient I had to diagnose at the VA with that. Eosinophilia also. Hyperpigmentation or vitiligo, which we just saw in that picture, and other autoimmune endocrine deficiencies such as hypothyroid, gonadal failure. Also have a patient with celiac. Sorry?
Right here.
Question.
Have you seen unexplained hypoglycemia in terms of like a neoplastic syndrome, like when you study obesity?
Yes, sometimes you can definitely see that hypoglycemia. Well, we see hypoglycemia in insulinomas many times. Yeah. But paraneoplastic syndromes, hypoglycemia, it's actually many times you see hyperglycemia more often because many of them have ectopic Cushing's, so they're present with new-onset diabetes. But you could certainly see hypoglycemia depending on what factors they're producing. Many of them, produce ACTH and glucagon sometimes, so they have glucagonomas, uncontrolled diabetes. But you could definitely see hypoglycemia also rarely. So, but more common in patients like the one we saw with adrenal insufficiency, and in younger children, many times growth hormone deficiency. You see that because they can't bring in the rescue hormone, as I showed in that graph. You have growth hormone as one of the last rescue hormone, and if you can't generate that, they do present with hypoglycemia. So, let's see. Any other questions related to that? Okay. So I think measures to prevent, as we to summarize this, since as you all go into every specialty, I think all specialties you end up dealing with steroids and adrenal issues, so it's very important. So the emergency card is very important, and I tell all my patients, show me the dog tag or your bracelet or whatever you have. So educate the patient and the family members. Sick day rule 1, double the routine oral steroids when patient experiences fever or illness requiring bed rest. When requiring antibiotics or before any small outpatient procedure, like dental work, usually it's outpatient, but you still want them to double their steroids. Sick day rule 2, inject a glucocorticoid preparation, IM or IV, in case of severe illness, trauma, persistent vomiting, or when fasting for a procedure like colonoscopy or surgical intervention. 100 milligram IV, IM or subcutaneous, followed by 200 continuous IV infusion every 6 hours when they're hospitalized. But I always give them a kit to hold on to. So many times they don't ever have to use it, but some of them like to have it when they're traveling or on vacation. It helps them. So let's see. Looks like I tried some graphics. So special attention to dose adjustment in sickness, and also emergent adrenal crisis discussion, and self-administration like we talked about, and going to the emergency room at immediately as soon as they recognize it. I think that's pretty much about, and also to let them know that we are always available. So, and usually we see them on a regular basis and do orthostatics and educate them about hydration. I've had one patient who was pretty dehydrated and didn't realize that can also trigger this. And so it's important to keep up with fluids. This is one group of patients you say it's okay to add some salt. More salt is actually better for these patients because they're on the fludrocortisone. So let's see. I think it's 1:40. I will skip these because many of these you already are familiar with, except secondary insufficiency and tertiary. It's important to know patients with sarcoid. Around Christmas Eve, I think we had a patient present with kind of ACTH deficiency. We ended up diagnosing her. I think Idana saw her in the clinic with us with sarcoid. She crashed at work and she was brought in, and then it ended up being neurosarcoidosis. Also hemochromatosis. Many of them who get diagnosed can have pituitary hemochromatosis. Important to remember with all your hereditary hemochromatosis patients. And lymphocytic hypophysitis, TBI, traumatic brain injury, which we see many of those patients in the VA. And after pituitary or any brain radiation for any other malignancy, over time they are at risk to develop adrenal insufficiency. So all of them need yearly evaluation of the hypothalamic pituitary adrenal axis. And let's see, ACTH deficiency. Okay, so next case, I guess we have time for a couple more cases. 50-year-old woman evaluated for muscle weakness that's developed over the last 6 months, weight gain, poorly controlled type 2 diabetes and hypertension, medications, metformin, 70-30, premix insulin, hydrochlorothiazide, lisinopril, amlodipine, and metoprolol. Physical exam, she does appear chronically ill. Blood pressure is sort of elevated. BMI is 44. She does have facial hair, which she says is new in the last few years, few months. Androgenic alopecia, which is male pattern baldness. Deep voice, which for her is new. She says when she calls her friends, they say her voice, sounds different. Central adiposity, and she does have some proximal muscle weakness when you have her sit in the chair and try to get up with the hands stretched forward. She's unable to do that. And she has to hold on to the railing when she climbs up even a few stairs. And she does have some edema also. Her labs, sodium is 144, random blood sugar 230. As we know, she is diabetic. Potassium 3.0. So your choices, I think many of you all probably know the answer to this. CT adrenals, MRI of the pancreas, C-peptide, GAD65 autoantibodies, or 24-hour free cortisol excretion. Or you call it UFC, urinary free cortisol. Any takers? I think everyone knows the answer. You're probably in a postprandial state. Okay. 1, 2, 3, 4, or 5. Free cortisol. Okay. So, can anyone else say why she said UFC? What is she thinking? Cushing's. Okay, I heard Cushing's, so that's correct. Let's see. So, anybody who complains of new onset proximal myopathy and poorly controlled diabetes, if sugars were very well controlled and suddenly becomes poorly controlled, and also if they are more hypokalemic, then you start thinking about Cushing's. And many times it can be very subtle, and many times the opposite is true. We can have what is called a pseudo-Cushing's, heavy alcohol use, severe depression. They can present with the similar symptoms of or have false positive pseudo-Cushing, which is like higher UFC and false positive DEX because of those situations. But majority of the times when you come in, especially a female who has alopecia, which is new onset, and hirsutism, and a deep voice and myopathy, they don't say striae. If they said striae, you would know the answer. That's why they didn't put in there. By the time they get the purple striae, it's kind of late already. So you want to pick it before they get to that point. So the answer is UFC. So does anyone have any questions related to the choice of 24-hour UFC? Asked. Yes?
The question is kind of pretty simple.
Similar, yes.
Go straight for low-dose expense.
Yes. So I was going to... Okay. So interestingly, and I had the same question when I was a fellow, and the way to approach is any time which there's data looking at both 1 milligram DEX and UFC. The UFC, for one thing, is not easy to collect, right? It's 24 hours of urine, and how accurate the patient can collect. And if you look, I didn't put up the study here, but if you look at the UFC collection, depending on the pattern of Cushing's, you could be in that 24-hour period actually when your cortisol levels were actually okay. So you can actually miss UFC. But if they put in 1 milligram DEX and UFC, I would have probably picked 1 milligram. But many times when you look at question answers, this has been for the last 15 years that I've done endocrine board review as an intern, as a resident, and as a fellow, is when they give you a choice of adrenal nodule and ask you to pick a choice, usually they give you 1 milligram DEX. But when they give you a patient with a physical presentation which may be suspicious of Cushing's, you always see UFC as a choice. But if I had to do what I had to do, I would have done the 1 milligram DEX, which is take it at night at 11 and come in. The problem with that, you have to review the medications. There are a few medications that will rapidly metabolize your dexamethasone, such as some older anti-epileptics. I've had that experience, and the patient's cortisol came back as 15 or something. So, and also the other side, which is true, is that the patient can be on birth control pills. And when you do their they can have a higher, result because of that. So if patients are on birth control pills, urinary free cortisol is better, because remember, with birth control or any estrogen or anything that increases the cortisol binding globulin will increase the amount of cortisol in your serum, but the free cortisol is more accurate. So there are a lot of caveats, so it depends on the patient, their convenience, and what you can do. And the third option is the late night salivary cortisol. Actually, I just copied this from your Mixapp and put it here. I know it's too complex, but they have a very nice algorithm, and that seems like something you could use. It's a little complicated, but I think when it gets to this, usually I've already referred the patient to endocrinology, but the late night salivary cortisol is something also that is very useful if you are having issues with the 1 milligram dex or with the UFC. LNC is also good because it is, again, free cortisol, so that's more accurate, and there's a lot more data on that. It's a little bit more expensive, and you have to have the right patient know how to chew and drool on it and then put it in the kit and send it back. So those are your three options usually. And while all of us wish that most patients that you get with Cushing's would be adrenal, because it would make it easier, because you do adrenalectomy and the ACTH is suppressed if it's adrenal. As you can see here, if it's ACTH, plasma ACTH is independent, it's usually adrenal. You go down this and do the surgery, but then majority of your patients will be ACTH dependent, and that's when there's much more involved, because in those patients, certainly majority of them have to have an MRI, and majority of them have to have a petrocell sinus sampling, which is done by neuroradiology, and we have a very good neuroradiologist here, and we've at least had 2 sampling done and had good outcomes. And ectopic ACTH is a problem because those are very sick patients. Those are patients with carcinoid or other malignancies, and the outcome is not great with those patients. They are much sicker. But usually this is where your questions usually would stop right here for internal medicine. So the fellows will get more of this. But it's pretty simple. You either, if there's a nodule, you go with the 1 milligram. If not, you go with the UFC. And then you remember, if they give you a list of medications like estradiol or something, then you don't want to do the 1 milligram dex. So, got it? Okay. Let's see. We'll probably just do... I think Raj is not here, but he had a question about the... so we have like 10 more minutes, right? He had a question about the... Okay, let's do this question, which will kind of segue to that. What happened to my questions here? Okay, 70-year-old woman admitted to the MICU. Pneumonia and sepsis. IV antibiotics are initiated. Of course, this patient... This is easy for you guys. You've all been through MICU, and we have great protocols now. Type 2 diabetes, metformin, glimepiride, basal analog, Gargin is her home regimen. She is septic, 102 temp, blood pressure is high, she's tachycardic, glucose is 300, and of course she is, at this point, how will you manage the glucose in this patient? So the first 2 choices are insulin drips, except the target glucose is different, 80 to 120 in the first one. Second one is 140 to 180. Metformin, which is her home metformin. Then basal bolus, 140 to 200 goal. And then no treatment for hypoglycemia, because it really doesn't matter whether you treat the sugar or not, because ACP says so. Any answers? Somebody other than Jara. 2. Perfect. You guys already know everything. So why did you pick 2? Can you tell me the study which had you pick 2? The reference study for the inpatient hypoglycemia? It's called the NICE sugar. It's easy to remember. It was in 2009. So before 2009, all of us would have picked number 1, because of lack of data in the medical ICU. If this was a patient whom they said is in the surgical ICU, is post-sternotomy, then your glycemic control would be much tighter because of the data from the Louvain study, which is the second study here, Vandenberg study, intensive insulin therapy in critically ill. So in 2001, in the first 10 years, we always kind of referred to this and everybody had tight control. But then in 2009, the nice sugar study, which was medical ICU, came out. And it was an international study with multiple centers, including Australia, many in Europe. So that showed that in the medical ICU, the outcomes were different from the surgical ICU, interestingly. So your conventional treatment, your treatment goals 140 to 180 worked just as well as the titer. In fact, the titer control did cause some negative outcomes. So for medical ICU, we use the more 140 to 180 treatment in these patients. But if you had a patient with sternotomy, wound infection kind of situation, used the surgical control. And I think he had a question about, so this is glycemic target. The rationale is right now 140 to 180, multi-center study. So for now, that's our answer. He's not here, but I'll just go over that real quickly about glucocorticoids and hyperglycemia. There are two ways to approach it, depending on the patient. One way is to look at, so the 30% increase is also a good choice, but one way to look at it is the patient diabetic or not, and how much insulin are you giving? What we describe as low-dose glucocorticoid dose is anything below 40 milligrams of prednisone, or I have the doses here, methylprednisone below 30, or dex less than 6 milligrams per 24 hours. If they're not diabetic, for every per glucocorticoid dose, 5 to 10 units of NPH, and if they're diabetic, slightly higher doses. And I think the residents who have worked with us are very familiar with this protocol that we use on all those high-dose steroid patients, which they use for induction after transplant in Jewish. And higher doses, again, 10 units NPH if they are not diabetic, 20 units NPH per glucocorticoid dose, which is equivalent here, 40 milligrams over prednisone. Then you do 20 units NPH per dose. Many of these patients get every 6 hours, 125 or 250, so we kind of go with that. The other option is to increase the basal, Lantus, or Levemir if they're already on it, but seems like in our experience, you seem to keep fighting to catch up. This seems to work much better. And once they get to a dose which is more optimal, like 20 or less, then we use their basal bolus. It's more convenient. And this is the protocol that we use here. I think it's in your resources in Cerner. This dose strength is there. It's based on the patient's weight and based on the amount of prednisone. So that is the answer. We also have a protocol for the enteral feeds, which we usually use basal bolus, and occasionally premix can also be used, but basal bolus is what we use, both for continuous and for bolus feeds. We use basal bolus. So that pretty much summarizes the talk. I didn't go into bone or thyroid, but certainly if anybody has any questions, you're welcome to email me or call me anytime, or work with us in our clinics. That's another way of getting it. Thank you. Any questions? No questions? Okay. Thank you all.